Good afternoon, colleagues. My name is Raymond Yeke. Welcome to this webinar where we are focusing on HIV prevention cascades. And we have aptly coined this the Harare prevention cascade. As has been highlighted, I think there are some instructions on the screen there in terms of interpretation. Also, that those who are joining us, can you please introduce yourself in the chat box so that we can move on to the business of the day. As I said, my name is Raymond Yeke. Can I hear someone responding that you can hear me? Thank you much for joining the webinar. Unfortunately, I have to join using my phone because I seem to be having connectivity challenges. This is basically a webinar where we want to focus on HIV prevention cascades, where we are sharing our experiences in using HIV prevention cascades in Zimbabwe. This has been made possible by our collaboration between the Ministry of Health in Zimbabwe, the National AIDS Council, BRTI, the South to South Learning Network. We also have been supported by the Gates Foundation for this activity. This is also a follow-up of a session that we had in ICASA 2023 in Harare, for those who were in Harare for ICASA, where we presented the work that we have been doing in HIV prevention. In addition, also, we have had interactions with colleagues in the region around supporting each other to develop HIV prevention. The Ministry of Health in Zimbabwe and National AIDS Council have already supported and worked with Botswana as well as Lesotho. And we actually have a pending discussion with South Africa to also assist them with prevention cascades. Then in our interaction with Prof. Gretson, we agreed that maybe we could structure this more appropriately by organizing these webinars and then bilaterally try and see how best we can support countries that may request further assistance or further collaboration with Zimbabwe in developing their own HIV prevention cascade. We have a PEG program, and our meeting is supposed to end in about 1.5 hours. And so I will immediately invite my colleague from the Ministry of Health and Child Health, Ms. Gertrude Nuwe, to give us the objectives of this webinar. So Gertrude, over to you.
Oh, thank you so much, Mr. Yeke. Good morning and good afternoon, everyone who is in this webinar. And thank you so much for actually participating in this webinar. My job is very easy for now. As Mr. Yege has already alluded to, our HIV prevention cascade, what we are going to share today with you are the objectives of this webinar. Next slide. So our objectives is to introduce the Harare HIV combination prevention cascades, analogs to the treatment cascade. And we want to share experiences, like it has been alluded that we actually presented this at the last ICASA here in Zimbabwe. So we want to share experiences from Zimbabwe on the utility and limitations of program-specific HIV prevention cascades. At the same time, we want to share the results and the insights which we gained from measuring the Harare HIV combination prevention cascades in population surveys in Manicaland, where we actually looked at Manicaland, which is in the east of Harare, one of the provinces, one of the provinces in Zimbabwe. And at the same time, we want to raise awareness of the South-to-South Learning Network, Zimbabwe-led initiative to promote measurement and reporting of the Harare surveys. Those are the objectives for for this webinar for today, and you should stay tuned for more webinars on these Harare HIV combination cascades. Thank you.
Thank you very much, Gertrude, for giving us the objectives of the webinar. And colleagues, we will move on to the next segment of the presentation. And we have two facilitators for this particular session, where UNAIDS and the ministry are going to lead. And we have Mr. Isaac Taramosi, who is an SI advisor at UNAIDS, a country office in Zimbabwe, as well as Ms. Anna Machia, who is our coordinator for the condom program in the Ministry of Health and Child. And so I will hand over to Isaac. Please remember, we are going to allow the presenters to run through their presentations. If you have questions, if you need any quick clarifications, please do not hesitate to use the quick Q&A section of the. So over to you, Isaac.
Okay, thank you very much, Raymond. Hello, everyone. I'm going to share experience of cross-sectional and chord measurement cascades that we had in Zimbabwe and we interface with other countries. Next slide. So my presentation is going to have three areas that I'm going to focus on: definition and rationale of HIV prevention cascades, and rationale for program-specific cascades, and I'll also give examples. So with that, I'll quickly move to the definition, how a cascade is defined. A cascade is a sequence of occurrence needed to bring about a desired outcome, which is a concept that is key and that can be defined by a set of indicators to make sure that you'll be able to take clients from one stage to the next stage, highlighting the attrition of coverage of eligible population across the stages or sequences of events in a continuum of care. So to achieve this, you follow through a result chain based on the program or specific intervention result chain so that you'll be able to identify bottlenecks in order to improve program and also to have the overall impact of the program. Next slide. So on use of these HIV prevention cascades, like for our experience, we've been using HIV prevention cascade to improve uptake of HIV prevention methods. So it aided in the implementation of our programs and changing also the implementation modality and target population to be reached, like in the PrEP, HIV PrEP program, our target population who were at risk. It actually aided in the improvement in the implementation of the program. It also helped us in tracking HIV prevention program and assess the opportunities that we have in HIV prevention, like in our target group, in targeting adolescent girls and young women, which happen to be a low-hanging group in targeting and improving program coverage towards epidemic control. It also gives us a leverage to say for the resources that we have, how can we mobilize more resources, especially by defining the gaps that we have in HIV programming, and also as an advocacy tool to say which programs do we need to focus on for us to achieve epidemic control. Next slide. So coming closer home, trying to also borrow the slide, next slide, borrow from the definition of an HIV prevention cascade that was given by Garnett Geoff Garnett, would find out that for us, our experience, we have noticed that with HIV prevention cascade, it has helped us to prioritize the population, like in Zimbabwe, priorities for the PrEP program for adolescent girls and young women and sex workers, especially in those key priority population programs like adolescent girls and young women, men who have sex with men, female sex workers, and transgender. It also gave us the leverage to be in a position to analyze the cause and effect. If you follow through the Bradford-Hill criteria, the theory of causality, what is inferring which, for us to develop innovative interventions like the issue of Kabla, the PrEP option that we have actually, and the delivery option that we have adopted. So through the use of HIV prevention cascade, we have managed to adopt innovative HIV prevention program and also deliver innovative HIV prevention modalities like the PrEP HIV prevention modality that we are implementing. Next slide. So with HIV prevention cascades, they are actually in two approaches, which can be provider-centric and user-centric, user or client-centric approach. So the provider-centric approach is the one that is formulated to reflect the steps in program, which means if you look at the provider-centric cascade, the second bar, it talks of demand generation, supplying of the products. And if the products are supplied, then we talk of the uptake of that product as when we have created demand. So these are the simple cascades that we have been using over period of time, and this can be drawn using program data in which we can also explain the program's implementation approach. Like as we implement our PrEP program, we can explain that since it reflects the program implementation, and we can construct this provider-centric cascade using our program data. The difference with the client-centric approach is when you look at the second bar, it talks of perceived risk, whereby someone would perceive to be at risk. There's a reason of uptake of service at individual level. And this can only be assessed and can be drawn, comprehensively drawn using population-based or survey-based data to be in a position to measure and draw the HIV prevention cascade. So it's formulated to reflect the reason why those in need of HIV prevention methods may not be using or may be uptaking those HIV, the motivation to uptake HIV prevention services. So these are key approaches, the provider-centric and also the client-centric approach that we have been using. And of late, our key main experience was based on the provider-centric approach, where we have been using also routine program monitoring data to. In summary, for this slide, I was saying there are two types, the user-centric and the provider-centric, where the user-centric is based on the motivation of an individual to provide, to uptake HIV prevention services, and this can be best measured using population-based survey to calculate the risk perception or how the individual is motivated. Then the provider-centric is based on the product that have been supplied, which means it's based on the demand that has been generated by the provider, which can be measured by program data. We can draw this by using program data. Next slide. Next slide. You can move to next slide if you can hear. Okay. So if you look at the this routine program monitoring cascade, where we use provider-centric, are often preferred for the following reason. Why? They are easy to design, then they focus on the implementation of the program, and they can be used also to check to say maybe what is the progress of the program. And since we can measure using existing data, in most of these cases, you can use the program-based aggregated data. And it's very simple to use aggregated data, as much of our data tools like DHIS2, they generate this data, aggregated data. Next slide. Next slide. Okay, so picking from the UNAIDS, the basic HIV prevention cascade model, where it talks of the first bar, the focus population, which happen to be our target population, for example, adolescent girls and young women, the population who might be at risk, maybe the number of female sex workers, if we are targeting 90% the female sex workers, it talks of the focus population. Then the second bar talks of the reach or coverage, where it talks to say maybe out of those which have been targeted, what is our reach or our coverage of the focus population. Then the third bar talks of uptake of the services among those who have reached or which you have reached with HIV prevention program, whether through demand that we've generated through this product that we have supplied, what is the proportion who have uptaked those services. And it also include, or it also combine with those who have used the services, which means it talks of the coverage and uptake and use of the services. And it also goes on to say those who adherence in the use of your services, we may have correct and consistent use of services, as the last slide. And this can be further also developed by talking of those who use the services. The intention is to avert infection. So we can add another bar to say maybe those who infection that have averted as a result of our program as a basic. So this is the basic UNAIDS model that you can find, that you can implement for HIV prevention cascades. Next slide. Next slide. Okay, so there are two analytical approaches for HIV prevention cascade. We have a cross-sectional analytical cascade and also a cohort-based cascade. The cross-sectional, it's mainly focused on aggregate indicators at a specific point in time. For example, by end of each year, you can have your analysis of the indicators for the program, so that you can see the flow and also where we have challenges in delivery of our programs. And this mainly based on numbers and proportion. What is the cohort-based analytical cascade? It takes into consideration a group or elements or group of people that you follow through with intervention. Like in Zimbabwe, we've been using this peer approach, the HIV prevention delivery approach, where we have sister to sister, brother to brother approach, female sex worker micro planning project, where we follow through a group of people over a period of time that are identified to be at risk, and we measure the attrition across the cascades. And this is key, and normally it requires unique identifiers. And we can also measure the attrition by calculation of the hazards at each point in time. Thanks. Next slide. Next slide. So what are the strengths of the cross-sectional cascades? It provides overall bigger picture along the continuum of care at one point in time, and it identifies the major leakages in the provision of care, of which this is key that can be used to improve also programming. The limitation, it doesn't reflect the program performance at a specific period of time, which means with that cohort-based cascade, they do better to reflect the performance, program performance over a period of time. Then, because it uses data from different sources, therefore, it's very difficult to have all the data at one source, especially when it's population-based survey data. And the challenge also of using data from different sources, we have challenges of missing data there. Next slide. And next slide. This is an example of a cohort-based cascade for the provider-centric approach that was done in Manicaland. That was done through serial population-based survey, where we have we have lack of availability, lack of uptake, lack of adherence, lack of efficacy, where we can see our focus population were people in Manicaland, where they were provided with medical male circumcision, voluntary medical male circumcision, and this has been published by Garnett et al., where you would find out at each continuum of care for us to measure this. It provides essentially to do repeated cross-sectional measurement as a source of our data. So with the limitation that we have been talking of, with the repeated surveys, there are times where we have no resources, where we won't be able to do these repeated population surveys to come up with these key data points or the indicators that we require to construct the cascade. Next slide. So if you look at the other analytical approach, the cohort-based approach, it tracks individuals through continuum of care, through the implementation of unique identifiers, and if the individuals, they can be tracked for a minimum of a year. And after a year, you can even calculate the infection rate, which means you can even calculate the incidence when you imply the cohort-based approach. And this code-based approach, you put people in what we call a model or a caseload, or people who would have been diagnosed of HIV during a specific time period. Then you enroll them in a cohort, then follow them through over a period of time for at least 12 months. And thank you. Next slide. Next slide. Okay, so what are the advantages of this code-based approach? It enables a robust evaluation of program performance at national or sub-national level. Like in this instance where we're implementing peer-led intervention approach, it helps us to evaluate the impact of those approaches. We can even evaluate to say the DREAMS project or the sister-to-sister project that we are implementing, how many infections that it has prevented, how many infections that it has averted. It's very much possible. Then we can track individuals also across the continuum of care, across specific time periods, and measure the performance of our programs. But the two big main challenges that we have with our code-based approach, it's a bit expensive, because we'll be following through people with continuum of care, with structurally defined services that we'll be providing to the cohort elements. And it requires also unique identifiers. So we need to have a robust M&E system using DHIS2 unique identifiers. And as a country, we've since implemented DHIS2 unique identifiers, especially based for these programs that are based on cascade model. Next slide. So for an example of a code-based cascade, we have a micro-planning, which is the sex work program cascade, where in our strategic plan, we had a target of almost 34,000. And through our coverage of information, we managed to reach almost like 37,000. And those who have been tested and those tested positive, initiated on RT and initiated also on PrEP. So you can check through the continuum of care with your cohort of people whom you can follow through over a period of time and come up with a cascade to say, where are we having some leakages? Next slide, so that I can demonstrate the leakages. Next slide. So if you can consider the following slide, demonstrate where we have the leakage, like for those who have been tested and those who have tested positive, then those who are eligible for PrEP and those who are initiated for PrEP. So you can see that for those who are negative, and the screening rate is at 53%, yet we might need to consider 100% screening for those who test positive to see whether if they are eligible for PrEP. So which means there is leakage. So the cascade, it also defines linkage in the continuum of care at each point of service delivery. And we can also see that linkage to PrEP, for those who are eligible, only 31% were initiated on PrEP. So you need to determine and assess the reason why that leakage, why there was only initiation of 31%. So it also helps us to identify and improve program on our program, especially in improvement of our program and access to services by population. That's when we also talk of key innovative intervention approach of using peer approaches for us to improve our programs. Next slide. Next slide. Okay, so these are just summary of other cascades that we have been implementing, like for key population programs, for men who have sex with men, for female sex workers, for DREAMS program approach, and for all the programs that we are implementing cohort-based cascade. Then we also have that we are implementing for other biomedical HIV prevention programs, like voluntary medical male circumcision, which we are implementing using the cross-sectional based approach. So these are just set of examples of HIV prevention cascade approach that we've been implementing as a country that we use to improve our the generation of data, and also for improving in decision making, and also generation of evidence that can be required also to improve our targeting and program coverage. Next slide. Thank you so much. Over to you, Anna.
Thank you, Isaac. Good afternoon, colleagues. I'm Anna Machia from Ministry of Health and Childcare, and I will be presenting on the next session. It will be a short session for just 5 minutes. Can we have the slide? So my focus is on a program record-based HIV prevention cascades. And we will maybe look at the strengths and limitations. And just maybe to introduce my session, these cascades are derived from program data and are dependent on the indicators that the particular program is tracking. So in terms of strengths, these cascades can be tailored to any given program approach and can be measured using routine program data. For stigmatized populations where denominators are measured using tailored methods, this can be more accurate than estimates from the population surveys. In terms of limitations, they generally exclude people not reached by the program. And it's for obvious reasons. We have no control as to compel maybe people to come for services. People come as and when they feel like they want to access that particular services. Denominators must be estimated, and there is little information on gaps in terms of demand and reasons for the gaps that we actually observe in these cascades. The cascades are also not generic, so they can't combine. So you can't actually combine to create a combination cascade. The advocacy value is limited to the specific program. So when you now want maybe to come up with advocacy, it will be like advocacy tailor-made for that specific program. For example, PrEP or condoms. Next slide, please. Okay, so this is an example of a program-specific cascade on adolescent girls and young women. So you notice that you can actually see from the graph or from the cascade that there are certain indicators there that are being tracked on target, you actually see that it's blank, meaning maybe that priority population in terms of size is unknown. So that's the reason for the missing data there. And the girls completed at least 5 prevention combination sessions. Those tested for HIV, those tested negative, and referred for HIV prevention. It is not possible to estimate the target or priority population, so this cascade provides limited information on the coverage of the program. The cascade doesn't provide any information on the extent to which the gap to HIV testing reflects lack of demand versus problems accessing the testing services. And the cascade does not have a bar for uptake of HIV prevention methods. So the way we also design our programs has a bearing on the quality of the cascades in terms of what we really want to measure. So it's always maybe prudent to make sure that you are agreed on the indicators that you really want to capture, so that you'll have a cascades that can make sense. Let's move to the next slide. Can we move to the next slide? So the other example is this cascade on men accessing VMMC services. We have the black bar there for reflecting the target. And then the next one is the circumcisions, the reviews, and the last bar, the adverse events. If you look at the target compared to the circumcisions, already there's some leakage, which is almost about half. And when you then maybe move on from the circumcisions themselves to the reviews, there's also a leakage that is observed there. And on adverse events, the cascade is actually silent. So this cascade provides a useful overview of key outcomes of the VMMC program and the numbers of men who are being lost between each successive outcome. The limitations include the absence of information on the high-level reasons for men not taking up the intervention, and for their not being followed up for the reviews. Again, probably because the men involved have not presented. It appears the slide is, yeah. So those are examples of program-specific cascades that I wanted to share with you. Thank you, and over to the next speaker.
Thank you very much, Gertrude, Anna, and Isaac for the presentations. And I'm just checking whether we do have a couple of questions before we move on to the next session. Are there any questions that have been posted in the chat? No, I know Jorgen raised something around saying something about funding for HIV prevention activities and the challenges. I don't know whether it's specifically for this group or for all the other speakers, maybe later on. All right, so I think in this case, I think let's move on to the next, in the interest of time, let's move on to Dr. Moyo, Brian, for the next presentation. So Brian, can you go ahead and make the presentation?
Thank you so much, Raymond, and a big thank you to the previous speakers. I'm going to just switch off my video. For now, my bandwidth is low, and I'll proceed with the presentation. Next slide. So I'm just going to talk about a bit more detail on the Harare HIV combination prevention cascade. I'm going to talk about the rationale for a generic HIV combination prevention cascade that is measured in population surveys. I'll talk about the development of the Harare cascade, and I'll show you the main cascade as well as the extended version. What you see on the right of your screen is the combination prevention interventions is defined by UNAIDS, being rights, evidence, and community-based programs that promote a combination of behavioral, biomedical, and structural interventions designed to meet HIV prevention needs of specific people and communities. But for the purposes of this presentation, by combination prevention, we mean taking use of one or more methods of HIV prevention as the final outcome, or bar, as you'll see in the next slides, in the main cascade. We also have an extended version, which will include the structural and behavioral factors. Next slide. So the Harare HIV combination prevention cascade was developed because so treatment as prevention helped bring down new HIV infections, but less quickly than we hoped for. New infections need to be reduced and kept low to limit the number of people requiring lifelong ART and to keep ART programs sustainable, especially in the view of decreased funding that we are currently seeing. Revived emphasis on strengthening primary prevention programs with the UNAIDS 95 targets. The treatment cascade was seen as very helpful in the scale-up of ART, and to reproduce the success for primary prevention, we need a unified HIV combination prevention cascade. To construct this cascade and to provide comparable information across methods, a generic cascade formulation is required. This would allow comparability not just amongst the methods themselves, but also among different jurisdictions. If the cascade is embedded in an explanatory framework, it can also be used to identify interventions to close gaps that are found in the cascade. Next slide. So the program or method-specific cascades that Taram Isaac and Anna spoke about have important uses and strengths, but they also have limitations for some use cases. The strengths would include they can be tailored to a particular program approach, and they can be measured using routine program data. However, they generally exclude people who are not interfacing with the health delivery system, if people are not reached by the programs, they're excluded from the cascades. The denominators or the focus of priority population therefore would need to be estimated. There's little information on gaps in the demand and the reasons for those gaps. It is not generic, so they cannot combine to create a single combination cascade. Advocacy value is limited to that specific program. Next slide. The Harare cascade formulation also has strengths and weaknesses. It is representative, gives a holistic picture that links to the UNAIDS 95 targets for people at risk to be using at least one method of HIV prevention. The Harare cascade is generic, so it can create a single combination cascade for high-level monitoring. And you can actually use this to compare with the international targets. It can be disaggregated, so it can identify gaps in method-specific programs. It is embedded within an explanatory framework, so you can conduct research to identify reasons why such gaps exist, and also evaluate the interventions that are more likely to be effective, as I shall show you in the next slide. That is to close gaps and to reduce new infections. They're suitable for evidence-based advocacy, for resources to focus on closing major gaps. The main limitations of the Harare cascade formulation: it requires a periodic population survey data, and that comes at a cost. There's limited flexibility to different method-specific program designs, but this can still be reflected in program-specific cascades when you use the program data. Next slide. So I'm just going to talk about the chronology of development of the Harare combination prevention cascade. And then I'll walk you through what the prevention cascade looks like. There were a number of earlier cascades and a lot of attempts to come up with the cascades. There was a Bill and Melinda Gates Foundation meeting that led on to some articles being published in the Lancet HIV supplement in 2016. Then there was the Zimbabwe initiative to develop a generic cascade and explanatory framework. Stakeholder consultations and the technical workshops were conducted in 2017, culminating in this that we are now calling the Harare cascade. Next slide. So this is what the main cascade looks like. I will just walk you through the main cascade, and then we'll show you the extended cascade that is within an explanatory framework. So the cascade starts with the first bar that looks at the priority population that would benefit from the prevention method. And then you see this is why you'd need a survey to do this. And then it also then goes on to look at from those in the priority population, how many are actually motivated to use the intervention. That is those who want to use the prevention method. And then from those who are motivated or who want to use the prevention method, how many of those can actually access the prevention method? And from those that access the prevention method, how many actually use the intervention method, the prevention method correctly? So the extended cascade then explains the gaps that are within the cascade. Next slide. You can push the animation. Next slide. All right, thank you. So you see, there is then explanation for the gaps that exist from each bar. For instance, out of the priority population, there's a gap of those who would not want to use the method. And the question is why? So there are issues around knowledge gaps, risk perception, perceived consequences of using the prevention method, and then the social acceptability of the prevention method. When you then look at the extended cascade, you also realize that there are interventions per studies that can actually address the reasons for lack of motivation to use the method. And this would include information campaigns, peer-based programs, sex education. Several platforms can be used like schools, media, both mass media and social media, community, and including through non-governmental organizations. From those that are motivated or would want to use the prevention method, there are those who would not get access. So there's a gap, and that gap can be explained. So lack of access can be explained on issues around availability of the method, ease of access, and acceptability of the method, and then also affordability. The explanatory framework also, the extended framework also gives us the interventions that can then be used, including mass distribution, outreach programs, integrated health services, legal challenges, for example, decriminalization of sex work. And these can ride on several platforms, including legal systems, the healthcare sector, the private sector, including non-governmental organizations. And then from those who have access to a prevention method, there are those who not use the method effectively. They lack capability. And the reasons that explain that include skills or self-efficacy, and then partner issues. The partner may not want that method to be used. And then the interventions in the extended or explanatory framework would include incentivizing use, behavioral counseling, empowerment, including strengthening women's rights. And then this can ride upon the legal system, health sector, the private sector, and as well as NGOs. Next slide. I think that should be the end of my presentation. Next slide. Oh, yes. And then the principal uses. And you can take it. Thank you so much. Interpretation, intervention needed, and then this can also stimulate research to answer the questions that may be arising from the gaps that are seen within the cascade. Thank you so much.
Thank you very much, Brian, for the presentation. I think let's move on to Phyllis.
Good afternoon, everyone. I'm Phyllis Mandejuza from BRTI, and I'll be walking you through the illustrative application of the measurement of the Harare HIV combination prevention cascade for adolescent girls and young women. I hope you can all hear me. Next slide, please. So the Harare cascade is currently being measured in the 2023-2024 Zimbabwe Demographic and Health Survey, and we hope to have national measurements to share in the next few months. In the meantime, we're able to share examples from pilot studies. The pilot studies have been carried out in 8 urban and rural sites in Manicaland, Zimbabwe's eastern province, as you can see from the map, using data from a series of 3 household censuses and population surveys carried out between 2018 and 2023. So the HIV prevalence from there was 11.7% in the pilot study areas in 2018 and 2019. Next slide, please. So the sexual behaviors associated with HIV, with higher HIV incidence rates in adolescent girls and young women, were identified in an earlier cohort in study in Manicaland. So in the 2018-2019 survey, 211 HIV negative adolescent girls and young women reported one or more of these behaviors and were taken to be the priority population for the HIV prevention in this demographic group. These young women, therefore, were taken to form the first bar in the HIV combination prevention cascade, as you can see in the next slide that's coming up now. So in this slide, this shows that the HIV combination prevention cascade for adolescent girls and young women were at a higher risk of infection in the 2018 and 2019 survey. So we first look at the overall height of the bars, and we can ignore the colors for now. So comparing the first two bars, as you can see, we see that there's a large proportion, almost 40% of the adolescent girls and young women at risk in Manicaland who are being lost to prevention because they are not motivated to use any method. Then comparing the third bar with the second bar, we see that more than half of those who want to use a prevention method are being lost because they don't feel being able to access this method. And then comparing the fourth bar with the third bar, we see that there are also quite a few of the adolescent girls and young women at risk who want to use a method and can access one, and who still don't use one because they lack capability to use this method due to partner opposition and or social practical skills. But now, as we focus on the color code, this shows that most of the adolescent girls and young women at risk who are motivated to use a prevention method want to use male condoms, with some who are also interested in using female condoms or PrEP. So you must be aware that during the time of this survey, PrEP was just being introduced for use in the general population in Manicaland in 2018 and 2019, which explains why it hardly appears in the access bar. So quite a few of the adolescent girls and young women who wanted to use an HIV prevention method reported being able to access female condoms. However, very few of these young women actually use female condoms due to lack of capability to use this method, due to partner opposition and or social and practical skills. Ultimately, only 1 in 7 adolescent girls and young women at risk were using an HIV prevention method, and almost all of these were using male condoms. Next slide, please. So with the Harare prevention cascade, it is possible to separate out and compare the cascades for individual methods on a like-or-like basis. So in this case, as male condoms were the only method being used by adolescent girls and young women at risk in 2018 and 2019, we focus on the cascade for this method, which is on your right. So as gaps were found between the main bars in the male condom cascade, we also measured and looked at the most common reasons reported for each of these gaps. Next slide, please. So as you can see these results more clearly in this slide. So the biggest barriers to motivation to use male condoms were lack of personal HIV risk perception, despite these young women having multiple casual or transactional sexual partners, and perceived lack of social acceptability. Then the biggest barrier to access amongst those wanting to use condoms was lack of acceptable provision for adolescent girls and young women, for example, due to lack of privacy. So the most common reasons for not actually using condoms amongst adolescent girls and young women who wanted to use them and were able to access them were partner resistance and lack of self-efficacy, or confidence to negotiate condom use with partners. Next slide, please. So in this last slide, for the HIV combination cascade as a whole, or for individual method, it is possible to disaggregate and compare the cascades for different population subgroups, for example, for different countries or regions. In the pilot studies, we compared the combination prevention cascade for different site types in Manicaland. What we found was much higher, but still lower than optimal. Use of HIV prevention methods in men living in urban areas to your left, and the other one in those rural areas to the right. So from the cascade, we see that this was due to greater problems accessing prevention methods in rural areas and in using methods when they could be accessed. A quarter of men in both areas lacked motivation to use a prevention method. In some cases, it may be that they didn't engage in risk behavior. So to reduce new HIV infections, programs need to identify and address the barriers men face in accessing and in using prevention methods, particularly in rural areas. Thank you, Mr. Lekere. Over to the next presenter. Thank you.
Thank you very much, Phyllis. Let's move on to Ngwarai.
Thank you very much. I hope I'm loud and clear. I hope, Mr. Lekere, you can hear me. My name is Ngwarai. Yes, it is reflected there. So I'm going to walk you through the steps that are involved in the construction of the combination HIV prevention cascade. I know, of course, yes, people have been asking questions. Isaac has actually shared, in terms of provider and the user, centric or, patient centric or client centric cascades. Of course, at times there is no single, cascade that can explain all, gaps that exist within our programming. But at times you might end up using, only provider where some information is not available. At times we use a combination. But however, when blending the two, approaches, I think we can come up with a comprehensive, a combination HIV prevention cascades for us to be able to explain. So I'm going to walk you through next slide in terms of, the steps that we need to use when we are actually, we want to increase the use of HIV prevention cascade, taking from, the Harare as an example. So the first step, I think, is for the chosen population method. For example, I think as was actually shared by previous speakers to say it could be adolescent girls and young women. It could be, VMMC clients, whatever the PrEP clients, those that are eligible. So we are supposed to measure the, the cascade, basically starting with the priority population. Then after that, we need now to say, let's examine the steps we need to establish where the gaps exist in the use of the methods. Broad targets for the interventions, as we are aware that use a particular prevention method, and if people are motivated to use, are they able to access this, the prevention method? And ultimately, we need to establish these 3 steps, in the cascade to establish where the gaps exist, because at times you can actually see that the first bar and the second, subsequent bars might be having, that gap or the difference between the phase. So we need to identify really, those gaps and be able now to say, using, I'm now on step number 3, using the available data, what could be the factors that would have actually contributed to those gaps that have been identified, between the bars. I think that's where we now need to make sure that as we are looking at a particular, population, it could be males, it could be females, those differences in the bars, we now need to make sure that we now interrogate to see what are the factors that could have contributed to those as we are analyzing the cascade. However, we move on to step number 4. We have to make sure that we use all relevant literature to say, to identify the interventions that have good potential to reduce the factors. Of course, some countries could have been literature, through, research that has been done by other people. They've tried this, they've tried that. So we need to make sure that we read through all the literature and use that relevant literature for us to be able maybe to explain and to try different, methodologies or approaches for us to be able to explain what could be, so that at least we are able to do, targeted interventions to address the barriers or the gaps that exist between different parts or along the continuum of care. Then after that, then the fifth one is for us to be able to say, having identified, those, interventions that might be a potential, then we now say, let's tailor make, these, selected interventions to suit within our epidemiological and socioeconomic status. Yes, of course, what could have worked in country X, Y, Z might not really work within our particular setting. So we now need to tailor make to say, is this relevant or not? Maybe some people have tried this, but their epidemiological or socioeconomic context could be different. Then we tailor make ours so that at least we target appropriately. Then last but not least, we now need to say, let's implement these interventions and steps and factors in prevention cascades as outcomes in this evaluation design. This last step is for us now to say, as we have actually, designed our cascades, and we've actually found out that these are the gaps that exist, and these are, the potential interventions that have worked, and we've selected, interventions within our country context. But now let's make sure that we write now explanatory, notes or factors that could really, be used for us to be able to do trials and see whether it works or not. Then we're able now to really revisit and see whether, the outcomes are the ones that we desire for us to be able to increase the use of HIV prevention within a particular setting and within a particular group. But I'm happy to say most of, the countries or within our country setup, we've disaggregated the data, by age, by sex, by client profile. So as we are constructing these cascades, we don't simply generalize, but focus on a particular, population group, so that at least as we do our interventions, they are targeted and they are right targets, or they are right, interventions for a particular, population group. So these are the basic 6, steps that we can use, and we have actually used or tried in Harare for us to be able to use or increase use of HIV prevention cascades. Thanks over to you, Mr. Chair.
Thank you very much, Ngwarai. I think we have, 2 more presentations from Constance.
Thank you, Mr. Yeke, but due to internet instability, I will be switching off my video. Thank you. I'm Constance Nyamkapa, and I'm part of the Manicaland Court. So what I'm going to be talking about is how we have used the Harare HIV combination prevention cascades with adolescents, girls, and young women. That is when we are looking at the reduction of lack of risk perception and barriers to PrEP uptake by this group. As we are all aware, the adolescents, girls, and young women are a priority population which is at higher risk of acquiring HIV infection in Zimbabwe and elsewhere in sub-Saharan Africa. However, few of these adolescents, girls, and young women at risk realize they are at risk. PrEP was introduced for use in the general population in Eastern Zimbabwe in 2018 and 2019. Enhanced PrEP awareness activities together with activities to improve risk perception were implemented with adolescents, girls, and young women in selected communities during the rollout period. We had a community randomized controlled trial that was conducted to measure the impact of these activities in increasing the risk perception and PrEP uptake. We also did PrEP cascade for adolescents, girls, and young women, which we measured before and after the interventions. Next slide, please. Okay, so what we have in the two figures at the bottom of this slide, we show how the main prevention cascades for PrEP had changed after 6 months in the control sites. These are the areas where there was no intervention at all. At baseline, when PrEP was first being introduced in Manicaland, demand for the method was very low in these control sites. After 6 months, about 1/3 of the adolescent girls and young women in these sites wanted to use PrEP, but actual use was still negligible. The two figures at the top of the slide show how the main prevention cascade for PrEP had changed after 6 months in the intervention sites. At baseline, the PrEP cascade in these sites was very similar to that of the control sites, if you check with the bottom bit. However, after 6 months, more of the young women in these sites wanted to use PrEP, approximately 3/5 as compared to 1/3. Slightly more adolescent girls and young women in the intervention sites were using PrEP after 6 months than was the case in the control sites. However, the absolute level of PrEP use was still low in the intervention sites. Next slide, please. The next slide shows the same HIV prevention cascades for adolescent girls and young women in the control areas and the intervention areas, but with the data on the explanatory factors that is displayed in the gray subbars. From this, we can see that, as expected, the low demand for PrEP in both sets of areas was due mainly to lack of knowledge about PrEP, but also to very few HIV negative adolescent girls and young women realizing that they were at risk of HIV infection. The increase in demand for PrEP seen after 6 months amongst the adolescent girls and young women in the control areas reflects mainly an increase in the number of these women who knew about PrEP. It increased from 35/355 to 198/355. However, most of those in the control areas who now wanted to use PrEP felt that they couldn't access it due to limited availability and the cost of reaching the clinics where it was being provided. In the intervention areas, the larger increase in demand for PrEP after 6 months than in the control areas was explained by a greater increase in knowledge about PrEP, which increased from 42 out of 341 to 270/341, and also a large increase in risk perception, which also increased from 42/341 to 199/341. However, lack of social acceptability for young women to use PrEP and the small numbers of clinics offering PrEP at this time were barriers that contributed to the small numbers actually using PrEP. May we go to the next slide, please? Okay. Now I'm also going to give another example at how we used the Harare combination prevention cascade to look at increasing HIV self-testing and PrEP uptake in men. Next slide, please. As we are all aware that men are vulnerable to HIV infection and are the main source of infections in women, men are known not to use clinic-based health services, including accessing HIV testing and prevention methods. The Harare HIV prevention cascade was measured in a population survey to assess the extent to which gaps in demand, supply, capability, and to use methods contributed to men's slow use of HIV testing and prevention. Where gaps in the cascade were found, the most common reasons for these gaps were established. This information was used to identify the program strengthening activities most likely to increase men's use of PrEP uptake. Next slide, please. We started by looking at the main cascade for HIV testing that we had previously measured for HIV negative men in our project sites. In total, roughly half of these men reported having had an HIV test, which is 1,488 over 2,955. The cascade showed that most of these men wanted to have an HIV test, but men thought it was difficult for them to access HIV testing services. And many of those who wanted to be tested felt that they could access HIV testing, but still hadn't used it. Next slide, please. Then we looked at the barriers for each gap found in the main cascade and found that, for example, low risk perception and negative consequences were barriers to motivation to take up HIV testing. Low perceived availability and lack of acceptable provision due to lack of privacy and inconvenient clinic opening hours were barriers to their accessing HIV testing services. And lack of partner support and low social skills were barriers to also taking up HIV testing in men who were motivated and could access testing. Next slide, please. Program strengthening activities were then identified to address these barriers. For example, the use of a confidential self-administered SMS-based HIV risk screening tool to improve risk perception. Distribution of HIV self-test kits through men's peer networks and community hubs to improve availability and access to HIV testing. Provision of community helpline to support men who need help or advice in using the HIV self-test kits. Next slide, please. Thank you. A similar process was followed with PrEP. This slide shows the HIV prevention cascade that was measured for PrEP for HIV negative men. Prior to the intervention, only 15% of the men were motivated to use PrEP for HIV prevention. Most of those who wanted to use PrEP didn't feel they could access it, and only a tiny number reported using it. Next slide, please. Thank you. When we looked at the barriers to motivation, we found out that lack of knowledge about PrEP, once again, low HIV risk perception contributed most to this gap in the cascade. For the gap in access, amongst those wanting to use PrEP, limited availability and the cost of accessing PrEP were the main barriers. Next slide, please. Thank you. Based on this information, program strengthening activities again were identified to address these particular barriers. For example, peer network distribution of HIV test kits, SMS-based HIV screening tool to improve risk perception and increase motivation to go to the clinic for confirmatory testing and possible initiation on PrEP. The community helpline to support men who need help or independent advice on PrEP availability was also availed. Thank you. I think that's the end of my presentation. Thank you.
Thank you very much, Constance, for the presentation. We will have the last key lessons. The next presentation, is it Gwarai or it's Mohammed?
Sorry, Mr. Yeke, this comes before Mohammed.
Okay, all right, that's fine then. So Gwarai, you can go ahead.
Okay, thank you very much, Mr. Yeke. I think now, before we wrap it up, I think from all the presenters, as we are hearing, we need now to summarize what are the key lessons and recommendations that we can make to other countries who might also want to adopt, the similar approach to the combination, HIV prevention combination, cascades. I think is based on mainly two areas. I think, in terms of the utility, in terms of the feasibility. So I think in terms of the utility, I think we found out that the measurements of the HIV prevention cascade in population surveys I think is quite, helpful in complementing existing program-specific cascades. I think it also demonstrated that, a single unifying picture of overall status of HIV prevention across all methods is quite possible. And also the information on the needs of people who require HIV prevention methods, but are not currently reached by the programs. There's also, they are also embedded within an explanatory framework. The Harare HIV, provides a clear pathway in terms of actions needed to close the gaps, found out in cascade, and thereby reduce the new infections. I think, of course, we've been talking about, those that are not reached. We know, of course, it's common across all the countries that they are hard to reach areas in terms of service provision, but we have actually made use of village health workers, lay cadres, etc., for them to be able to get, closer to where people are. So through the use of cascades, you are able now to identify, to say, for this priority population, why are we not getting the right, outcome we require? Then we can actually find that they're hard to reach areas which can also be accessed using different, methodologies. In terms of feasibility of measuring in national survey questionnaires, I think when countries believe it will be useful and request, this can be possible. I think you can actually see that within different countries, we have got statistical offices, we have got organizations that do surveys. So some questions can also be added within these, surveys that, are done by different organizations. For example, in Zimbabwe, currently we are doing the ZDHS, and we've added some questions that tend to address, issues of, combination HIV, prevention, so that at least we are able to construct these cascades. And if anything or any information or there exist any gaps, we are able now to explore and find ways and means of addressing such, gaps. We've already done this in the ZDHS, which is currently underway, which other countries can also adopt, and this can actually be used as we actually construct and develop, HIV prevention cascade. So we encourage, therefore, to encourage other countries to measure and report it in the forthcoming national surveys for their own internal use, so that comparisons can be made across countries, as has been done with the treatment cascades, which are measured in the FEAR surveys. So in general, people can actually, if they are happy or they can adopt it, you can also include some questionnaires, which, you look at our Zimbabwe Demographic Health Survey, the questions in the past surveys, which was last done in 2015, did not include these questions, but we managed to make sure that we also include questions which, when the report is written, can reflect the gaps that exist. And as prevention program, we are able now to tailor-make interventions for us to be able to address such areas or where gaps exist. Thank you. Over to you, Mr. Chair.
Thank you very much,
Mr.
Ngwarai.
Yeke.
Yes, thank you very much, Ngwarai, for the quick summary. I think let's move on to Mohammed's session. So Mohammed, over to you.
Thank you, Raymond. Hi, everyone. So I'm just going to touch very quickly on Zimbabwe's SSLN initiative to promote measurement and reporting of the Harare HIV prevention cascades in national surveys. So to begin with, the SSLN and Zimbabwe champions, with support from Imperial College London, have committed to a partnership where together we will support the application of learnings from Zimbabwe's prevention cascades into other countries. We aim to share these learnings from Zimbabwe and build capacity of other countries to take on the HIV prevention cascades independently. And through our experiences, we found several countries across the continent have had quite a strong interest in HIV prevention cascades. The gap has been in learning and applying these learnings in a very tangible way. So we have a structured approach on these learnings. And one of the key enablers in peer learning is, well, to have peers. Based on today's experience with Zimbabwe, we know that we can draw on a pool of experienced trainers who would be able to share their practical learnings with others to build skills. In the next slide, I'll share our thinking on structured knowledge and capacity building, leaning on familiar SSLN learning activities. Next slide, please. From this webinar, we would like to hear who would be interested and committed to building their capacity with prevention cascades. We plan to roll out a set of link and learn sessions which lean on the peer-to-peer approach, whereby others would be able to learn from Zimbabwe in a facilitated space for deeper conversations amongst implementers. And we want them to take those learnings back home to be applied. This will open the conversation to a more focused country-to-country mentoring approach. And here we aim to have a few selected countries who would be undertaking a population survey within the next 9 to 18 months. And the learnings there would be valuable in building the cascade and informing your country's prevention landscape using relevant and fresh data related to your context. Through these processes of engagement, we'll facilitate the building of skills and encourage countries to opt into benefiting from the cascades approach. As you've seen today with the examples, there are multiple uses for the cascades in programming that can be disaggregated to priority and key populations as well. Throughout this process, we hope that the countries will be able to independently apply cascades relevant to their needs and geographies. Next slide. In order to opt into this offering, please do reach out to myself as well as Simon, and our emails are in front of you right here. And as a number of you are already country champions, you would also be able to reach out to your country engagement leads or even through our website. And we'll be sure to include you in these upcoming activities. Thank you. Back to you, Raymond.
Thank you very much, Mohammed, for that. I think we have come to the end of our presentations for this webinar. I'll probably just check if there are questions, if there are comments or clarifications based on what was on the chat box. I don't know whether people had immediately responded to on the Q&A section, or there are people with specific questions. And maybe I'll just do a quick run through in terms of those that presented. I don't know, Isaac, did you have any questions directed to you? So the session where Isaac and Anna were presenting, did you have any questions?
Thank you, Raymond. I had a couple of questions and I have responded to them in the chat box in the Q&A question section. Thank you.
Thank you very much. Anna?
I didn't see any questions
directed to you. Okay. Okay. And then the next block of presentations were Brian. Any questions that were directed at you, or you responded?
Yes, so I didn't see any specific questions directed to me. Just some comments, but no questions. Comments. Thank you.
Thanks very much. Phyllis?
Yes, I did have a couple of questions and I've responded in the chat section. Thank you.
Thank you. Thank you very much.
Thank you. Yes, I don't think there is any specific questions, but I can see that there is another question maybe which is more general in terms of how we are reaching out to, underserved areas, bearing challenges of, remote and unserviced areas. I think maybe I said this when I was presenting. We know in Zimbabwe we are using, like, for example, integrated sample transportation to say, of course, we might be having some village health workers or riders who are working in a particular area. So if it is issues to do with testing, issues to do with specimens, transportation, we have to make sure that we do our things in a harmonized approach, rather than to say this is a sputum for TB, this is a specimen for EID. We as much as possible, we use the community based workers to provide some of the services, and we also do outreach services especially for areas that are underserved or remote areas, so that at least all the clients will get the services that they require, and in the process we'll be able to achieve the desired goals of preventing HIV. Thanks. Over.
And thank you very much, Ngwarai, for that response. Constance?
No, there was no question directed to me.
Okay. Thank you. I noted a question on, I think from Yogan, on resources. And yes, I think for Zimbabwe, definitely, and maybe I'll also ask Gertrude if she's on the call to chime in. But we are operating in a constrained environment in terms of resources, particularly for HIV prevention. Of course, generally, we are beginning to experience a shrink in resources available for HIV. And one of the things that we are currently doing is developing a sustainability roadmap. But for HIV, we definitely are having challenges around fully implementing what we desire in terms of expanding access to HIV prevention services, including making sure that all the options are available at the right places, and people have access to those services. We do have an AIDS levy, and about 20% of that levy is dedicated to support HIV prevention. But this is maybe 20% of something like between $45 and $50 million. And certainly that's a drop in the ocean in terms of what we require for HIV prevention. Even when we have been mobilizing resources and we are developing either concept note for the Global Fund or HOPE, we still face challenges in terms of making sure that the envelope expands. I think in the last envelope, in the last grant, which is GC7 that we are currently implementing, we have actually seen a shrink in our allocation for HIV prevention. So yeah, I think that's the long and short. But Gertrude, I don't know whether you have any additional comments around access to HIV prevention resources.
Oh, thank you, Mr. Eke. I think you have actually said it all. We are really constrained, as you have already said. Thank you.
Thank you very much, Gertrude, for that. I think we have come to the end of our webinar, and colleagues have already sort of summarized the next steps. We are ready, and as Mohammed has said, we are working closely with SSLN and BRTI to ensure that we provide the necessary support tailored to the needs of our colleagues. And we also note that this also provides an opportunity for us to learn from other countries
on how we can also improve our own cascades. Otherwise, thank you very much, everyone, for joining us today. And we look forward to interacting in the future. Thank you.
Thank you, Chair. Thanks, everyone.
Thank you, everyone.
Thank you, everyone.
Bye. Take care.